Yeah, ma'am. We are on live, ma'am.
Yeah.
Yeah, ma'am. So very good evening, Doctor.
Welcome
Ma'am,
to
I will introduce
all.
myself. Yes, ma'am. Yeah, ma'am. Just I'll give you introduction, ma'am. Yeah, very good evening,
Yeah.
doctors. I am Dr. Stalin on behalf of Shield Healthcare, welcoming you all for the today's webinar uh, arranged by A4 Hospitals and Fertility Center. The topic for today's discussion is GDM Screening and Monitoring. I welcome Dr. K. Balakumari, ma'am, who is going to be the today's moderator for the session. Ma'am is the alumnus of Stanley Medical College, and Madam is currently heading the Clinical Obstetric Department of A4 Hospitals. With this short introduction, I welcome you, ma'am. I'm handing session to you for further proceedings, ma'am. Welcome, ma'am.
Thank you. Gestational diabetes mellitus is a topic which is very dear to me. 40 years ago, when we finished our MBBS, even when we did our post graduation, it was hard to find a diabetic woman. Of course, that time the extensive screening was not there, but at least a random blood sugar was taken for every pregnant woman. But the amount of obesity, I started feeling this trend even in 2005 when I started my own hospital. But then, even when I started my hospital, I did a small study from my patients. It was around 10. The organizer, please mute all the others except the speaker. Mute.
Yes, ma'am. Yes, ma'am. Done, ma'am.
Yeah. Um, but now almost every fourth woman or the fifth woman that I see is actually a GDM patient, and many of them, of course, in spite of our warning and telling them the complications of gestational diabetes mellitus, they don't give much importance. So public awareness is still lacking, I feel. And Dr. Mohan, I should say he is an embodiment of intelligence, curiosity, dedication, and achievement. He is the chairman of Dr. Mohan's Diabetic Specialty Center. That center is an Indian Diabetic Federation Center for Excellence in Diabetes Care. He is a chairman for about 50, they have 50 diabetic centers all over India. And he is also the chairman for Madras Diabetic Research Foundation, which is an ICMR collaborating center for excellence. And he has published a record number of 1,783 papers, and I think many more are coming. I think every patient of his gets into the research group. He has almost 7 lakh patients with electronic medical records. He is one among the pioneers to do this sort of electronic medical recording, and as well as conducting so many researches. He makes us all feel proud. He is from Chennai, Tamil Nadu, and from India, and that is really very good thing for us to feel. He is ranked among the top 2 scientists in the world and top 0.1 scientists in diabetes. He was awarded the Padma Shri, the fourth highest civilian award by India. And it is not just that researchers, he has conducted more than 3,000 free diabetic camps along with Sri Satya Sai organization, and he has published nearly 40 books. His own autobiography, Making Excellence a Habit, that is a wonderful book. I would recommend, I have read it. I would recommend all of you to read that. Although also the other book, Banting, Bose and Beyond. All of you should read, and it is really motivating. His father was the pioneer in diabetic research. Even before everybody thought diabetes will blow up like this, he started a exclusive diabetic center in Rayapuram. I have gone to that center. In fact, soon after my post graduation, I attended on GDM meeting. I got more confidence from that only for prescribing diabetic medicines and insulin to diabetic patients, GDM patients. And here, Dr. Mohan, he is going to present us. We are happy to be associated with you, sir. Welcome to this webinar, and we would like to listen to your insights, and we would like you to guide us as to go about how to screen, monitor, and treat GDM. Welcome you, sir. Please take over the stage.
Thank you, madam. Thank you, Dr. Balakumari, for this very kind introduction. Although I've heard of Dr. Balakumari through many people, particularly through Dr. Sudha Vidyasagar, who introduced us, and very recently she visited our institution. But very quickly, she's not a person who wastes time on too much on talking, but she believes more in action. And her passion for GDM is very well known, and it came through very strongly when I met her very recently. And the first thing she said was, "Why don't you give us a webinar?" Because she is now heading the obstetrics and gynecology unit of A4 hospitals and fertility center, which is doing excellent work on all aspects of OG, and therefore it's a great pleasure. I've also invited some of my consultants and other colleagues for this symposium. What I'm going to do, and I understand that this is the 38th series, and this need not be the last one which I'm participating in, because we can talk on many other aspects which are of common interest to us. What I thought and I can see that there are so many associations also associated, FOXY and FOG and many other organizations. So this is a huge team.
Yeah.
Nagarajan, please mute, please. Dr. Nagarajan, yes, thank you. It's a great opportunity. Today, what I'll do is I will give a overview of the GDM screening and monitoring. The reason I'm doing that, not straight away going into this can be done, that can be done, is because there may be people who at various levels of understanding of GDM. Some may be freshers, others may be very seasoned in this. So I thought the first half of my talk, I'll give a very general overview of GDM, and for those of you who know GDM, it may be just a revision for you. But then I'll go on to some of the more recent research updates and something which we have been doing also at an international level. A lot of changes are coming in the field of GDM in the last 1 year or 2 years. That is very important for you to know. So I'm not just going to talk about screening and monitoring, although I'll start. So this is my agenda. I'll start with what is GDM, then talk about a little bit about the burden of GDM, risk factors and management, and then go on to what we are doing on GDM, and hopefully we'll be able to collaborate with the A4 hospitals and other collaborators. So GDM, as you know, is defined as glucose intolerance of any severity with first onset or recognition during pregnancy. A very old definition, as you can see, 1998 itself, Metzger described this. And it is basically not changed. If you detect diabetes for the first time during pregnancy, it's called as GDM. Of course, when you use this definition, it does not exclude the possibility that diabetes could have antedated the pregnancy. That means somebody already had diabetes and then you don't check, and then you Nagarajan, Ranyan, please mute. Yeah. So it is possible that they have pre-existing diabetes, but for that we have certain cut points. For example, if you do HbA1c and then you find HbA1c is very high, it is already pre-existing diabetes or pre-gestational diabetes. Whereas HbA1c is not high and then the sugar is high, then it's come during the pregnancy. So why does it occur? Now there are two main things which occur. First thing is, pregnancy itself is a state of insulin resistance. So as the pregnancy advances, there is more and more insulin resistance because of the human placenta lactogen and many other hormones in the body which change. Now, normally, even though insulin resistance is there in all pregnant women, they all don't get diabetes, they don't get GDM. But if you have a beta cell dysfunction, if your beta cells are not able to match that insulin resistance, when you have insulin resistance, the beta cell, the pancreatic beta cells put out more and more insulin. But if you're not able to do that, because the lady already has a family history of diabetes or a tendency to GDM, then the glucose level will go up and then she develops GDM. So that is what is shown here, that and this also has other other features which can affect the fetus as well. Now, when you have hyperglycemia in the mother, this hyperglycemia then stimulates the fetal growth, and that is why you get a big baby. Of course, in very severe diabetes, it doesn't happen. The baby can become SGA, small for gestational age. But in GDM, invariably macrosomia is what happens, and that's because of hyperinsulinemia. there is also more lipid and glycogen deposition. Now, the complications of GDM are very well known to you. Most of you who are listening to this are OGians. You probably know this better than us. But there are short-term and long-term effects, including cesarean section is more, preeclampsia is more, oligopolyhydramnios, miscarriages, fetal death. GDM in the future also can come, not just now. And of course, mother, future type 2 diabetes and future cardiovascular disease can also come. Neonatally, these are the things which occur in if you have GDM. Macrosomia I told you about. Shoulder dystocia, because the big baby, shoulder dystocia, difficulty in delivery, even perineal tears and injuries are very common. Hypobilirimia, congenital malformation, neonatal hypoglycemia, because they are treated with insulins on birth trauma, premature birth. And of course, the child also, when the child grows up, can get obesity, type 2 diabetes, cardiovascular disease in adulthood. Now, that's just a brief thing about GDM. Now, GDM in Western world, if you take Europe, you take US and all these countries, the prevalence of GDM is about 6%, 8%. Between 100 pregnant women, about 6 or 8 will have, and they think that it is very high. For some strange reason, in South Asia, India, Pakistan, Bangladesh, Sri Lanka, and so on, they have much higher, Nepal, they have much higher rates of GDM. We are still trying to find out why that is so. Madam mentioned that obesity rates are going up. So that's definitely one of the causes, but there are obese women in the West also. So there is some genetic factor which makes us more prone, and we are doing a lot of research on that. According to the IDF, the prevalence of GDM in India varies from 9% to 27%. Globally, it's about 15%. But in the advanced countries, it is much less. It's only about 8% or so. This is a study which Dr. Bavdarani, who used to work with me earlier, and colleagues, as part of the WING study, which I'll talk about, we reviewed the entire literature, and you can see that the prevalence rates vary so much. Some are reporting 2%, some are reporting 40%. It all depends on who you screen and how you screen, what criteria you use. All these, of course, make a big difference. So you really cannot give too much of importance to this. In fact, we have some national data coming out from the INDIAB study, which we are now writing up. And according to that, the prevalence of GDM has increased so much all over India. In that study, we use the same criteria for the whole country, and it is very high. Believe me, it is going up very high. Now, if you look, this is Dr. Sheshaya's study, where he looked at Chennai and semi-urban areas and rural areas. And this some time ago, almost 15, 18 years ago, this 17 years ago, it was done. At that time, the prevalence of GDM was about 18% in a city, about 14% in semi-urban. Even in rural areas, it was about 10%. Today, in the ICMR INDAP study, which we are going to publish, urban-rural difference has disappeared now. And within 15 years, rural areas also, it's about 20%. And in urban areas also, it is 20%. I'm not showing that data because it's not published. Now, this is another study which we did, which again our colleagues, as part of the IDF-funded study, this was done. This is called as a WING study. I'll talk about that, where we looked at the GDM prevalence using IADPSG criteria and the WHO 1999 criteria. And you can see that using the IADPSG criteria, the prevalence of diabetes is actually higher than the WHO 19. So WHO 1999 used one cut point only. OGTT done in the fasting state, 140 milligrams per deciliter, single cut point for diagnosis. In IADPSG, fasting is also used, fasting above 92. That is why the IADPSG criteria shows slightly higher prevalence. And in rural areas, these differences were much more. Again, as I said, this is an older study. It's about almost 9 years old now. Now the prevalence rates have changed and is going up very rapidly. Risk factors for GDM, easy to remember the rule of 25. If your age is more than 25 and if your body mass index more than 25, then you are at risk of developing GDM. Of course, family history of type 2 diabetes, previous history of GDM, and of course, Indians are more prone to get GDM. Management of GDM, very quickly, I'm just giving you an overview of GDM so that I can talk more about the more recent ones. So in the management of GDM, GDM is not like pre-existing diabetes. We have type 1 diabetes or type 2 diabetes going through pregnancy. you will need insulin, and you need insulin 3 times a day or 4 times a day. Whereas in GDM, it's much milder, and therefore, with the diet itself, medical nutrition therapy, and little bit of walking and all that, about 80% of people, 85% of people can be controlled. Our choice is insulin only for treating GDM, because after all, it's only for 2-3 months. If it's late GDM, which comes in the after 24-28 weeks, about only few weeks, and even one shot of insulin may be sufficient to control. So we always believe in giving insulin, but more and more people are using oral anti-diabetic drugs like metformin. We'll talk about that. So this is a study which was done to look at the medical nutrition therapy, and the main thing is to see that the lady gets enough calories so that ketonuria and ketonemia does not occur. It's not good for a lady to starve. So you give enough calories, see that carbohydrate is about 50%, then fat, give healthy fats, and protein, enough protein must be there, enough fiber must be there. You should avoid artificial sweetened beverages because these are contraindicated during pregnancy. All the sweeteners and all that you should avoid. Physical activity is very important. If they can do about 30 minutes of walking, it is very good. If they are not able to do the walking for any reason, then even upper body resistance has been shown. Louis Jovanovich showed that even upper body exercises are quite good. Now, insulin remains the drug of choice, and if after 2 weeks of medical nutrition therapy, if the fasting and postnatal is very high, you can start insulin straight away. If it is mild, then for 2 weeks you try medical nutrition therapy. If the fasting still remains above 95 and the 2-hour value above 120, then you have to start insulin. What about metformin? Now, the mixed study, metformin and GDM study, randomized 750 women to receive either metformin or insulin, and they looked at all the primary outcomes of neonatal hypoglycemia, respiratory distress, and so on. What they found was that 92% of women continued metformin to term. So there is one view that they can metformin if you are having PCOS and you are on metformin, you can continue up to the first trimester, then you must change to insulin. But in this particular study, they continued until term. What they found was that about half the women needed insulin. So that's one of the problems with metformin. Even if you start metformin, about half of the people will need supplemental insulin therapy, and that's what the mixed study and subsequent studies were shown. But there were no serious adverse effects, and of course women preferred metformin to insulin because it's only a pill and is much easier to take. What about glibenclamide and other sulfonylureas? Better to avoid them because they, although they do not cross the placental barrier, especially glibenclamide, but however we still don't know about their teratogenicity, and therefore other drugs, all other drugs, not only glibenclamide, but DPP-4 inhibitors, definitely not pioglitazone, and even the GLP-1 receptor analog, more recent SGLT2s, they are all contraindicated during pregnancy. If at all, metformin is the only drug which can be used. Now, having given a quick overview about GDM in general, let me go on to talk about some of our GDM projects. One of the first projects that we did was called as a WINGS project. WINGS stand for Women in India with GDM Strategy. This was funded by the International Diabetes Federation. They got support from the Abbott Fund, but we were funded through the International Diabetes Federation. Now, the whole idea, it wasn't a research project, but it was an implementation project. We wanted to train women, train healthcare workers, train support staff, train everyone, produce IECs. So we had a number of aims. The first one was to develop the WINGS model of care toolkits, and then to identify sites in a network of collaborating centers. And unfortunately, at that time, I didn't know Dr. Balakumari. Otherwise, I would have taken her. But for all future projects, we'll definitely include the A4 hospital. Then training programs were conducted, and then we implemented a model of care. This model of care was very simple: diet, wellness, how to screen, use it OGTT, use IADPHG criteria. Then if they don't have diabetes, and screen them again later part of pregnancy. Then if they have diabetes, treat them with the diet, then if necessary with insulin or metformin or whatever, and then follow them up, achieve the targets, and then see what happens to them. And the results were spectacular. I'll show you the results. Now, for example, this is a paper that was published in Journal of Obstetrics and Gynecology. where we looked at the pregnancy outcomes. So we gave the women with GDM the structured model of care. Right from diagnosis, we followed these women, carefully followed them up, and then we saw how much improvement we were able to get in these women. Can we bring these women just like non-GDM women? That was, and Dr. Umaram, who many of you know, was the main person in this particular study. You can see that virtually in between the GDM and the non-GDM women, there were some differences, but otherwise there was virtually no difference between, no serious side effect. Look at this. You look at macrosomia, look at preeclampsia, and all the side effects that we talk about. None of them were significant between the GDM group and the non-GDM group. These are not small numbers, 212 GDM and about 836 non-GDM. None of them reached statistical significance. So we concluded that if you follow these GDM women properly and develop a proper model of care for all these women, if they're taken care of, good pregnancy outcomes can be obtained. That means GDM women can be treated like a non-GDM woman. And that was a fantastic result which we got in the study. There was also a very important point. Now, women with GDM, one of the big problem is till they are pregnant and till they deliver, they will listen to you. You tell them to do blood sugar twice a day, they'll do it 6 times a day. You tell them to come every 4 weeks, they'll come every 2 weeks. Whatever you tell them, they will tell them insulin, they will take insulin. Ask them to come fasting, they'll come fasting. They are so motivated that absolutely no 100% compliance we get. But the day they deliver, they become completely different people. They will completely forget about themselves. That's a typical mother. So they'll only focus on the child. Now, mother also is like that. And sometimes the mother-in-law will also be there. And the mother-in-law will say, now you look after the baby, you don't go for your checkup and all that. So in India, a lot of cultural barriers. But this is not only in India, abroad also, very few people. The postpartum screening, we are supposed to screen every lady for GDM to see whether they have type 2 diabetes. But only the screening rates used to vary from 14%, 20%, 25%. The highest which was achieved in a randomized clinical trial till we did WINGS was 60%, only 60%. So and another study had 53%. So we told, when our WINGS team started this, we told them, please get the women back, please get the women back. WINGS has to show that it is possible to get women back. We must beat this 60%, try for 100%. That is what we said. So this was a paper which was published where we looked at the glucose tolerance status of women 6 weeks to 1 year postpartum. And what we found was that even by 6 weeks, some of them were actually developing pre-diabetes and diabetes. And by 1 year, quite a lot of them had developed. That means by 1 year, about 20% of all the women, GDM women who are followed up, had either developed diabetes or pre-diabetes. And we know that if we follow them for 5 years, 50 to 70% will develop diabetes. So that was something new which we showed. But look at this. What is most important is, except for 9 women out of the 212, 203 out of the 212 came back for their postpartum follow-up. This is 96%, 95.8%. This is a world record at that time when we published. And this didn't come easily. We kept telling them at every visit, come back, come back, come back, come back. And then at the end, when they delivered, we gave them cards, we told them thing, and then we said, if you don't come, we'll come to your home, and then we'll follow. With all that, we were able to get near 100% follow-up. This had never been reported in the literature. And this was, and this is the first point, is that when you start screening, even by 6 weeks, some are developing diabetes or pre-diabetes, and by 1 year, almost 20% are developing. So you have to follow up these women. So that is one advice that I would like to give you. In all your A4 hospitals, when you have GDM women, kindly put into place one person, either a social worker or a dietitian or somebody who will be dedicated doing only GDM work, who will contact every GDM mother and see that they are followed up for the pregnancy, after the pregnancy, for the postpartum follow-up to see whether they've got diabetes. This will be a great service that you're doing to them. Otherwise, what happens is, They will leave it for 3-4 years. Then the HbA1c will go to 10 or 12. They'll come, they'll put on a lot of weight, and then they'll come and then they'll eat 2 times insulin or tablets or 3 times, and they get depressed and all kinds of things happen. A golden opportunity to prevent diabetes we are losing. And the number of women with GDM in India runs to millions. So millions of people with diabetes can be prevented if we all work together. Now I'm going to completely switch tracks and tell you about a new entity which is not taught in textbooks, which has not yet come even to journals. Only now it is beginning to come. Traditionally, it was believed that gestational diabetes mellitus comes in the later part of pregnancy, second trimester, third trimester of pregnancy, 24 to 28 weeks. In fact, all the international guidelines only say screen between 24 to 28 weeks of pregnancy. The DIPSI guidelines actually, even in 2006, had said let us screen in the first trimester of pregnancy. Not necessarily for GDM, but because diabetes is so common, pre-diabetes is so common in India, even at young age, that we are going to wait till 24 to 28 weeks. All the time the lady will be having the sugar and we are going to miss. Therefore, earlier itself we started saying that let us start screening in the first trimester. But till now, we thought first trimester screening was only to rule out pre-existing diabetes. Now we are beginning to realize that GDM can also come in the first trimester of pregnancy. We call this as early GDM. And the other one which comes later, what we conventionally call, we call it as conventional GDM, or now we call it as late GDM. So you got early GDM and you got late GDM. So two types depending on when you pick up the GDM. If it's diagnosed before 20 weeks of gestation, we call it as early GDM. If it's diagnosed after 20 weeks of gestation, either 20, 28, 24, even 32 weeks, or if you diagnose, it's called as late GDM. So remember these two terms, early GDM and late GDM. One of the things which I wanted to talk to Dr. Balakumari when I met her was that let us not miss this early GDM, because early GDM seems to be even more severe than the late GDM, which I will show you now. Now, how do you diagnose early GDM? Till now, we don't have clear-cut criteria. In 2010, after the HAPO study, when the IADPSG criteria was introduced, they introduced a criteria to diagnose early GDM. If the fasting is more than 92 and less than 126, that is 92 to 125, they called it as early GDM. And that is the criteria which is being used. We are also using that criteria only because no new criteria have come till now. But after Metzger described this in 2010, a lot of people criticized it, saying that 92 milligram, 93 and all you are calling as GDM, many normal women will have that and so on. So they withdrew the criteria. They got scared and they withdrew the criteria. But they didn't introduce any new criteria. So till today we have got only one criteria, that is the this criteria which was introduced. That is another thing that we can do. As part of our collaboration, we'll be able to suggest, most likely what I predict is that this fasting is going to be increased, maybe 95, maybe the cut point, because TOBOGM study showed that. I will show you the results. But NICE criteria in US uses 100 milligrams. Maybe it's a bit high, but NICE criteria is using 100. 92 is definitely too low. You'll make a lot of false positives if you use 92. But till now we don't have a criteria. In course of time, the next year or two, you will find the criteria for early GDM coming. These are changing time. A lot of changes are occurring. Now, Wesley Hanna was one of our PhD students, and when she started her PhD, we told her, you work on early GDM, because this is something, and this paper was a systematic review, very good systematic review she published in Acta Diabetology in 2022. She collected all the data up to 21-22 and then published it. So what she found was that there were a lot of papers, but it was a big mess. Everybody is using different criteria, different thing, and so on. So what she found, about 58 studies which had screened before 24 weeks. And look at the prevalence of diabetes, varying from 0.7, this is worldwide, not India. So 0.7 to 37%, because different people were screened, different criteria were used, everything was different, okay? But the usual risk factors came out, BMI, previous history of GDM, family history of diabetes and all that came out. She also looked at what are the studies which reported on outcomes. So 23 studies reported on outcomes. So were the outcomes the same as the late GDM? Yes, because macrosomia, cesarean delivery, hypertension, preterm delivery, shoulder dystocia, all this was seen in early GDM also. In fact, the need for insulin was higher. In late GDM, I told you only about 10% or so need insulin. Here it is probably higher. There are studies which also looked at how many people convert to diabetes who have the early GDM. It seems to be higher than the late GDM. So for all these reasons, we proposed that more studies are needed in early GDM. Okay. At that time, we took up another study with UK, and this is called as the STRIDE study. So it's an Indo-UK study funded by the UK. It stands for Stratification of Diabetes in Early Pregnancy, STRIDE. Now, the aim of STRIDE was not to pick up early GDM. The aim of STRIDE was, okay, they're going to develop late GDM in second 24, 28 week. Can we identify some risk factors by which we can say which women are going to develop GDM? Nobody has thought about that. They wait for second trimester, then some women get it, then they start. Can we start in first trimester and then start? So we wanted to develop a risk score. Today we have developed a risk score using HbA1c, age, BMI and so on, which can help to predict these women. Large study, 3,000 women, 18 to 50 years. And these are all the collaborating centers. We have Dr. Umaram here, and then we have Dr. Saravanan Ponuswamy, who is the PI from UK. And then we have Dr. Deepa, Dr. Anjana, and others. This is Hannah. So we have all of them as part of this. So these are all the sites. We had Sitapati Clinic, EV Kalyani, Andhra Mailasabha, VHS, Fernandez Hospital in Hyderabad, as well as JIPMA. So this represents lower income group, middle income group, higher income group. And we had Hyderabad, Chennai and Puducherry contributing to the study. What we did was, we took 3,000 women, then we did early fasting glucose. Now, if the fasting blood sugar is more than 126, that is diabetes. Okay, diabetes count. We had 8 women like that, we excluded them. Then we had women who had less than 92 milligrams fasting. So we called them as normal. If it is between 92 to 125, we called it as early GDM. So that early GDM, we had 566 women. Then we had the normal women with less than 92. We waited for second trimester. We did OGTT using IAD-PSG criteria. And then some of them turned out to be normal, 1,500 people. And they were normal. They were normal through. They're normal women during pregnancy. Then we had 359 women who had GDM at that time. They didn't have in the first trimester. So they are called late GDM. We also call them conventional GDM. So you had eGDM, conventional GDM, and the normal women. All the 3 groups we had. And this paper is just being submitted for publication. And what we did in this paper was we compared the late GDM with the early GDM and the NGT group. You can see that the late GDM, the early GDM women diagnosed in the first trimester, slightly older, the weight was slightly more, BMI is slightly more, waist is slightly more, glucose is slightly more, HbA1c is 0.1 more. And this is not diabetes. Many often I am asked, oh, maybe it's early GDM or diabetic. 5.3 HbA1c is not diabetic. Okay, 5.1 is normal, 5.2 is late GDM, 5.3 is, so it's only 0.1 different, but that makes a lot of difference. And venous glucose you can see 83, 84, 97. And venous HbA1c also we did point of care HbA1c. So all higher in the early GDM group, showing that they are a little bit more severe than the late GDM. What are the risk factors for this early GDM? If you have a BMI is higher, overweight, HbA1c is slightly higher, and if you had GDM in an earlier pregnancy, recurrent GDM we call it, they are at higher risk of getting early GDM. Now this is a paper which we published in Lancet Diabetes recently, where the question we asked here is, should we do GGT in everyone, or can we use HbA1c at least to screen out and to screen? HbA1c is not a good test for diagnosing GDM. Everybody knows that sensitivity is too low. I talked about 5.1, 5.2, 5.3. With 0.1, how can you diagnose? So that, and a lot of, it takes standard deviation, it is too much. But we said, can we avoid GTT in some people? So it turned out very interesting paper where we said, if the HbA1c is 4.9 or below, okay, forget about it. They will not have GDM. If it is more than 5.4, they will almost definitely have GDM. If they may not even need to do GTT, fasting, postprandial, whatever you do should be sufficient. But if they are between 5 to 5.3, they should go for the GTT. For us in India, it doesn't make any difference. Everybody can call for GTT. But in UK and all, they're very fastidious. No, we won't come for GTT. We won't do this. We won't do that. So this is mainly for UK, USA, where they don't like to do GTT. So if you don't want to do GTT, if it's very low or very high, don't do it. But if it's in between, 50% of people only need to, 50% of women only need to come for GTT. Now let's come to the more important thing. This early GDM we have talked about. Should it be treated or not? Is it safe to treat it or not? Is the treatment effective? Okay. The earlier studies until about 2 years ago, very small studies, 10 people, 20 people, 30 people, all confusing results came. In fact, some studies say don't even treat early GDM. It's not a proper GDM at all. So we had to do a proper randomized clinical trial, international one, on a big numbers, randomizing women into treatment, no treatment, and seeing whether it works or not. This study is called as TOBOGM study, very famous study now, treatment of booking gestational diabetes, TOBOGM study. It's the world's first multi-center randomized, just like the HAPO study, the same group who did the HAPO study. So we screened women before 20 weeks of gestation, and then we use the same IID-PSG criteria to screen because we didn't know what criteria to use. So same criteria which is used in second trimester, we used in first trimester also. And then we tried to see what happens. This was published in New England Journal. I'm very happy that I was also one of the authors, and our group here was also included. We are the only center, only MDRF was included from India for the study. So very happy, because in the HAPO study, one of the criticism of HAPO study was that India was not included. So when they called us for the TOBOGM, we said yes, we are joining, because we don't want them to say that India is not part of it. So this is a very important paper. It's being quoted again and again and again. This will change the way GDM is being diagnosed. So these are all the investigators, and as I said, from India. They also had from Austria, from Sweden, and so on, and India. But most of the people were from Australia itself, from Sydney or from Melbourne. Now what we did was, we screened a large number of women, and if they had high sugar in the fasting, they either diabetic or pre-diabetic, we excluded them. Then if they had the GTT criteria showing GDM, then we called them as early GDM. These early GDM, we had 800 of them, and what we did was, one group we treated, okay, that's called intervention group. The other group was a control group. We did not treat at all. And of course, there's another decoy group where we pretended to treat, but we didn't treat, to make the study without any bias. And then there were normal women also, 2,400 normal women with no GDM at all. Main interest was in these two, the intervention group and the control group. You may say, after diagnosing GDM, early GDM, how can you have a control group? You have to treat them. Well, we don't know. Till the RCT was done, we don't know whether it should be treated or not treated. So suppose they get all side effects after treating, then we should not treat at all. That's why you need the first RCT, there is no ethical concerns. Based on what the RCT shows, then rules will change. Then only the ethics part of it comes in. So to cut a long story short, we found that in the intervention group, the primary composite outcome, preterm birth and trauma, respiratory distress, need for phototherapy, stillbirth, neonatal death, shoulder dystocia, was reduced significantly by treatment, and this was significant. P-value was P equal to 0.2. So the conclusion of the TOBOGM study was that yes, it is beneficial to treat early GDM. There were no significant differences in hypertension or lean body mass. They didn't become smaller because you treated. There were no significant side effects. Now, I told you in the beginning itself that this IAD-PSG criteria of 92 had been criticized. We thought this is the time to solve that issue. So, although we used 92 to screen, we divided our women into two groups. One we called as the low band GDM. There, the fasting was between 92 to 94. The 1 hour value is between 180 to 190, and the 2 hours between 153 to 161. Okay. Then women had higher glucose value. We call them high band, starting from 95 to 109 fasting. 1 hour is more than 190, 191. And the 2 hours 162 to 199. So these are the usual cut points for IAD-PSG. That's called as low band. We used a higher band to see which group benefited better by the treatment. And here are the results. You can see that in the lower band also, there was some benefit of the treatment, but it did not reach statistical significance. Whereas in the higher band, clearly there was a 7 times improvement compared in outcomes compared to the control group, and highly significant statistically. Okay, we also saw women, we said we took below 20 weeks. We saw below 14 weeks if they were diagnosed, just at booking if they were diagnosed, and little later after 14 weeks, which did better. Of course, everybody did better. Anything on this side of the 0 means it is beneficial. Anything on this side means it is bad to treat. Nothing was bad, all were good. But the women who were diagnosed earlier, they had better results. And the women who had higher glucose level, they benefited better. So what we concluded was that TOBOGM study provided the proof of benefit of treating eGDM. This beneficial effect was demonstrated for the first time in the world in an RCT, and therefore it's going to be game changing. The results were more significant in those who had a higher glycemic band and those who were screened before 14 weeks of gestation. Many other studies were published. I'll just rush through them because I'm going to finish now. It was cost effective. You may ask, is it cost effective? Yes, it was cost effective. We also found that if you start treating the eGDM early, they do much better than if you wait for the eGDM and then you start treating them later, they don't do so well. And then we also showed that the postpartum conversion to diabetes is much higher in the early GDM. Now the next question is, you said Indians were included. Not only Indians were included, South Asians in Australia were also included. So is this relevant to us? Do we have more eGDM or they have more eGDM? The answer is very clear. South Asians, we had Europeans, we had South Asian, we had East Asian, we had Middle Eastern, and then we had Maori and Pacifica, the Aboriginals. We had the highest prevalence of eGDM compared to any other race in the TOBOGM study. You can see the odds ratio. If you take Europeans as 1, it is 2.43, much higher than any other group. And even compared to LGDM, LGDM is also highest in the South Asians. But if you look at eGDM, it is even highest. That means these findings are very relevant to Indians. Okay. Now, why do they get early GDM? In this is not our study. We looked at another study where we measured the insulin level, C-peptide level, beta cell function. You can see that the eGDM is not producing enough insulin compared to the late GDM. This is all the late GDM. Early GDM, they are not having enough insulin. That is why they are getting diabetes very early. So I'm going to end by telling you that the current paradigm of treating GDM is in the first trimester you screen, but only for type 1 and type 2 diabetes. What you screen in second trimester, 24-28 weeks, is for GDM. That's the old paradigm. The paradigm is now shifted after TOBOGM. You screen in the first trimester, of course, to rule out type 1, type 2, but also to detect early GDM. And what you detect conventionally in the 24-28 weeks, that's called late GDM. So now we have to think of early GDM and late GDM. We have to do much more research to find out that genetically they are same or otherwise they are same. All those things have to be done. Which associations have accepted this? The first to accept in 2024 was Belgium. So the Flemish consensus, they have said, please screen in early GDM. And they have used the higher cut point, the higher band of TOBOGM, 95 and above, to screen. And they're saying that is a cut point. This 92 is too low, 95 is much higher. Australia has also accepted. The Australasian criteria is also saying 95. So it looks as if 95 is going to be the cut point. And even for us to treat, I think 95 and above, and then 190 and above for 1 hour, and 162 and above for 2 hours seems to be a good one. So to conclude, GDM is rapidly rising. If not managed, and lead to all complications. We showed through the WING study that through a low model of care, we can get results just like, but of course in WINGS we studied only late GDM, we didn't study early GDM. So the results can be like non-pregnant women. Medical nutrient therapy is enough for about 80% of people. But then if it's not achieved, insulin is a treatment of choice. Metformin can also be used. Early pregnancy screening is very important as it helps to identify not only pre-existing diabetes but also early GDM. Now early GDM is occurring because of the more insulin secretory defect. TOBOGM study has shown that treating early GDM is good, and then the higher band, those who have more than 95 fasting, and if diagnosed before 14 weeks, they seem to do well. No significant adverse effects of treating early GDM. It is cost effective. We have the highest prevalence of eGDM. Therefore, these studies is most important for us. We have to do it. And many countries have already started accepting eGDM. I hope India also accepts. I hope all you OGians start accepting early GDM and start treating it. My one message to all of you is early GDM must be identified and treated. For those of you who are not on my social media channels, you can take a picture of this. I'm on everything: YouTube, Facebook, X, Twitter, Instagram, LinkedIn. Any one of them you can join. Every single day I will give you a message. That's my email ID if you want to write to me. And those are our websites. You can take a picture of this. And more recently, I've started a WhatsApp channel. And if you actually scan this WhatsApp picture here, you can straight away, it will tell you follow. And if you just press follow, you become my follower. I already have about 7,500 followers on WhatsApp channel. Every single day, 365 days a year, I will be in touch with you. I will give you some message, not just good morning, good evening messages, but I will give you some inspirational quote every day. And I also keep talking about all scientific studies. Every week, at least one or two, some new point in science we'll be teaching you. So that's one good way by which you can be in touch with me. So if you scan that, you can do that. So now I'm going to stop sharing and we have time for questions now. Over to you, Dr.
Sir, how early do we screen? Like some people come with just 4 days delayed periods. Urine test is just positive. I haven't even done a dating scan. Can I go for a screening at that time?
Even at that time, you can screen to roll out pre-existing diabetes. But once the scan is done and once you have confirmed that pregnancy is definitely there, at that time you can start screening, because early GDM seems to occur even by 10 weeks. In Russia, where one of my colleagues works, they tell me that they start screening by 6th week of pregnancy. I said, so early? So the Russian thing is to screen by 6 weeks of pregnancy. We normally screen by about 8 to 10 weeks, 12 weeks, we start screening. The earlier you screen, they seem to do better. So at booking, when they come to book with you to continue the treatment with you for antenatal care, that time itself you do the glucose test. If you're able to do a GTT, then nothing like it, use IA-DPSG criteria. If not, at least a fasting and HbA1c, it will at least rule out pre-existing diabetes. And if it's above 95, you can say that GDM is there.
Okay, for practical difficulties, I'm saying when she comes to me around 6 weeks, I do a hemoglobin A1C. First visit, we do a hemoglobin A1C for everyone. Then I might ask her to come 2 weeks later for a dating scan. So that time, she do
is coming in the morning. If you do a fasting sugar also is okay.
No, the problem is like they may not be able to come with fasting to us.
Okay.
So can they do home glucose monitoring?
They can do. So you ask them to check, give them a glucometer, or ask them to do a thing, or ask them to do in a lab nearby, send you the result. Anything can be, whatever is convenient for you, you can do. Or at the next visit when they come, ask them to come fasting. If the HbA1c is below 5, it is very unlikely that they have GDM. If the HbA1c is above, say 6, they are already pre-diabetic or diabetic. If it is in between, say 5.5, 5.4, 5. Then they are the ones who need to be urgently, either you do a GTT or a fasting. They are the ones who are likely to have the early GDM. So the HbA1c is still useful that way.
GTT fasting, is it 100 grams or 75 grams?
75. 75
grams.
Yeah.
Then
it's 75 grams.
1 or 2 hour values.
Yeah, 1 or 2 hour values. Yes.
Okay. And weight loss in first trimester, like I have been advising my patients, this is not based on any study or anything. Because during pregnancy with hyperemesis, they lose about 5 to 7 kgs. Nothing happens. So on the same principle for obese people, I say even it is okay to lose weight in the first trimester. What's your take on that?
I leave it completely to the OG people. I think you all know your rules much better. So because at that time, in the first trimester, I think the ideally, if they are planning a pregnancy, the weight loss must be attempted before they get pregnant, because that will
Yep.
actually help to prevent GDM itself. If they come to you and say, I'm planning to get pregnant, can I get pregnant? If you find that they're overweight, put them on a diet, put them on something, make them lose 4 or 5 kilos in weight. Then if they get pregnant, that's the best. But suppose they're already pregnant. Now, I mean, to advise weight loss at that time, I don't know how already hyperemesis and all that is there in the first trimester. And I don't know whether pregnancy is the right, at least if you prevent excess gestational weight gain, that itself is a good thing. Because if they put on, because you have to eat for 2 people and then they put on too much of weight gain, that they'll develop GDM definitely, and then they won't be able to lose that weight also. So I think whatever you generally follow for your, if they're not diabetic also, whatever you follow, same rules can be continued as far as the diet as well as the weight gain, except that if they are diabetic, sugar they have to cut off, and maybe carbohydrate they can replace a little bit more protein.
Many of the centers, they prescribe protein supplements right from the beginning, even if the woman is obese. What's your call on that? I mean, like I have been telling,
I
I
don't
hardly
think.
write
I
any
think
health.
from diet itself you will get. We don't know what those protein supplements contain. They may be processed. We don't know what all they put into that thing. So unless there's a protein deficiency, if they have milk, if they have even they are vegetarian, they have some kadala, pairu, sundal, something, and then they have paneer, and there are enough vegetarian sources. Non-vegetarian, no problem at all. Fish, chicken, egg, all that will give you. If on top of all that, if they are anemic, they are undernourished, they feel protein supplement is needed, then some of the safe protein supplements. But routinely giving everyone protein supplement, I don't know whether that is really needed.
I
All
mean,
you
it's
have
not
to
even
take a
protein
cut
supplement.
down. So sorry.
It's
Sorry,
not even protein supplement. They are given a health drink.
that is, we don't know what that health drink is and what it
Like
contains.
all this Mother's Horlicks, all those things.
Most of them will
We got,
contain sugar, no. So they
yeah,
most of them contain sugar, which is probably excess calories and not needed. I think on a
concentrate.
case-to-case basis, they can take. Otherwise, I don't think it is needed.
Do you give a diet chart to all these GDM
We do.
women?
Definitely we give. Definitely we give. Because
Okay.
that is the main treatment for them. We also ask them to increase their steps. What we found was that even if 1000 steps per day they increase, we can't expect them to do 10,000 steps and all that. But from their normal, which is totally sedentary, even if they increase 1000 steps a day, it has tremendous benefit during pregnancy. So it is very good.
Okay.
And diet, we definitely give them a diet sheet. We ask them to avoid sugar. We see that enough protein is given, enough fresh green leafy vegetables, so that B12 and all that B12 deficiency will not come, and anemia also gets corrected with spinach and things like that. So diet we definitely give to everyone.
For a non-compliant woman, do you use a psychologist to motivate them?
I think during pregnancy, most people are motivated, but we do have some people, and for example, I have type 1 patients who will continue to eat sugar even during pregnancy. Whatever you tell them, they don't listen. There are a few like that. We just have to pray that everything happens okay, and then guide them as much as possible. They are exceptions though. Once they get pregnant, even the most non-compliant will become compliant if they care for the baby. If they don't care for the baby and they have some psychological problem, then they will not listen to anything.
What's the use of continuous glucose monitoring during pregnancy? Do you
Fantastic.
recommend?
It's fantastic. We are now doing a study on that. In fact, one of my colleagues, Dr. Baudharani, she has written a review article on this. And that is also we are publishing, showing that there is need for continuous glucose monitoring, especially if they have GDM or diabetes complicated pregnancy. CGM is definitely beneficial.
Okay. Do you want it throughout pregnancy or maybe
No, not necessarily. If they are type
days
1
after
diabetic,
surgery?
throughout pregnancy. In some type 2 diabetics also through GDM once or twice just to see whether they are under control. Even if they put one patch for 14 days, that itself may be sufficient for them.
Postpartum, how long do you want the follow-up, sir? We usually follow up to maximum 6 weeks. We review and then we advise them.
6 weeks
how
is
long
good
do you like?
to know the initial thing. But at 6 months to 1 year, see, up to 6 months they are doing breastfeeding. So getting them before 6 months is very difficult. After 6 months, the baby is they're not they're not doing exclusive breastfeeding, and they're beginning to move about and all that from outside the house. So that is a time when we have to catch them for 3 months, 6 months, any one time. Call them for a GTT, so that will help to say whether they are pre-diabetic
GTT you
or
want?
GTT should be done. Otherwise, but not the pregnancy GTT, not the pregnancy of 0, 1 hour, 2 hour need not be done. The usual GTT fasting, again 75 grams, fasting and 2 hour, that is sufficient to classify them normal,
Fasting and 2
pre-diabetic,
hours.
diabetic, like in a non-pregnant state. That way, GTT only will tell us whether they are diabetic or not, unless they come with very high sugar. Suppose fasting is 150, 200, HbA1c is 8%, then you don't need GTT. Then you don't need, but otherwise you must do a GTT for, and then if they are normal, maybe after 2-3 years again they can come. That and all they're not going to come. At least once we are able to get them at 6 months to 1 year, that is good. There are a few in the chat box, ma'am. I'll quickly take them.
Yes,
Can you explain about monitoring of blood sugar? So if you see the Western guideline, they say that GDM has to monitor 6 times a day, 5 times a day. In our monitoring of during our model of care for wings, we said you do once a day, once or twice a day, or even 2 or 3 times a week. Even with that, we are able to get good results. So it depends on the sugar level, depends on the HbA1c, severity. If they are pre-existing diabetes, you will have to do more. If they are GDM, even 2-3 times a week, one fasting in a week, one after food in a week, or something like that, even that is enough. And of course, continuous glucose monitoring is very important. So glucose profile, we did that. What is the treatment target for high band EGDM? Whether it's high band or low band, the target is the same. Try to keep the fasting below 95, even below 90, and the 2-hour value should be below 120. If you're able to do that, it is good. Insulin is my first choice, Dr. Kilivalvan, but sometimes metformin is used. MNT can be used with milder cases, but if the HbA1c is slightly elevated, if the sugar is slightly high, start with insulin. We don't have time to waste, so quickly we should start. Again, Dr. Kilivalvan, what is the treatment target for that we finished? How much HbA1c is reliable, approved method, and why don't you go for postprandial? For not postprandial, post glucose is the, because prandial means is it idli or dosa or rice or chapati or how much they ate, or 2 idli or 4 idli, or standardization becomes with idli in my house, your house is different. So postprandial is enough for control after diagnosing, but to diagnose, glucose is the best test. HbA1c is not reliable, and for doing, we don't recommend in India at all, because in the UK they wanted rule in, rule out. We are using it. How much carbs do we advise? See, we don't recommend too much of carb reduction, but you follow the plate principle. In the thali plate principle, try to take half or quarter of that plate with vegetables. Quarter of the plate should be for protein. You take Bengal gram, green gram, black gram, whatever, rajma or non-vegetarian, and then the last quarter of the plate you keep for chapati or rice. So that's how you get the carbs. Then patient on metformin, PCOS, how do we screen them? Now the PCOS is an independent risk factor for GDM. That we know that. We have another paper, which is a major paper from TOBOGM, which is coming out, showing that PCOS is a independent risk factor. So you have to keep screening them. They are a very high risk group for GDM, and therefore the moment they get pregnant, you will have to. Of course, continuing metformin is not a bad idea. You people know that better than me. There is no contraindication, but if they need insulin, we should give that as well. Can you prescribe strength training in the first trimester and second trimester? That's what upper body exercises have been shown to be good, so we can do that. It depends on whether it's a high risk pregnancy or not. Continuing metformin in pre-existing type 2 diabetes PCOD. I don't think there's anything wrong in it. There is some, Dr. Arun Kumar has asked, there's nothing wrong in it, and many studies are showing that metformin is okay, but the last word on that has not been told. Proteinuria, GDM with proteinuria, Dr. Honey wants to know. Well, proteinuria is a bad sign, especially if it's a persistent proteinuria. It may be pre-eclampsia or eclampsia setting in. It could be diabetic nephropathy. GDM generally doesn't produce microalbuminuria or proteinuria unless you have hypertension. So proteinuria is not a good sign. Whether it's a temporary due to some urinary infection or contamination or something, you have to repeat it and see how much is the proteinuria. But it's not a good sign. It's a warning sign. Dr. Bhavesh, anemia, hemodilution. Yes, of course. Not only HbA1c in pregnancy, even outside pregnancy, these are all the things which affect HbA1c. Dr. Soham Sanyal, what is the best option to treat diabetes during lactation, new onset diabetes? Studies have shown that the tablets really don't do much harm. They believe that sulfonylurea will come in the breast milk and can produce hypoglycemia. I have not seen any case. If you're very, careful, you can continue insulin. But then when the delivery is over, at least metformin they can change too. So I don't think these things are secreted in milk to an extent to produce hypoglycemia in the child. It's more of a theoretical thing. New onset type 2 diabetes developed after GDM around 2 months postpartum. Yes, it's common. That's why I said within 6 to 8 weeks they can develop. Within 1 year they can develop. If they miss that, within 2, 3, 5 years they can develop. Different people, depending on the genetic tendency and the weight and so on, they can develop, and then you have to start treating them. Is there any role for low birth weight baby use of metformin? Low birth weight is one of the side effects of metformin. They say that the baby tends to be small, but it's a controversial issue. Most OGCians who use metformin, they say no, nothing like that happens. I leave it to you. My personal choice is insulin. I am a diabetologist. My personal choice is insulin only. I've covered all the questions in the chat box. If there is any other question anybody wants to ask, you can ask. Few more minutes, otherwise we can wind up. Anybody else? Any question? Role of OGCT. GCT. This is a screening test, the glucose challenge test. So you give the glucose challenge test, and then you see whether it's above 140 or not. And if it is above 50 gram glucose load is typically used. And then if it is above 140, you send them for OGTT. It's a two-step procedure. For women who don't come fasting, at least you do this, and then as a screening test, you can, even in the non-fasting state, you can do it. And then if it's above 140, you send for a definitive test. I don't generally recommend the DIPSI method. As a screening test, GCT is okay because you're going to then do the OGTT. But using that for a diagnosis alone, the sensitivity is very low because already the sugar is high when you've eaten. And now you go and give glucose on top of that, the sensitivity becomes very low. So that is why I prefer the IADPSG criteria. Which insulin to use in long-active one? Tresiba is also allowed now. Lantus is also allowed. Then you have Detimir, which is Levemir, which is allowed. And of course, any of the other insulins. No insulin is really contraindicated during pregnancy. HbA1c target for planning a pregnancy for a known type 1. Below 6.5 is ideal, at least below 7 before they plan the pregnancy. 6.5 will be absolutely safe. Today we have pumps, and with insulin pump, the sugar will come down so beautifully. There will be no fluctuation. HbA1c can come to 6%. So the insulin, the current pumps that we have are fabulous. It's almost like a cure for type 1. And so they are costly, but sometimes we give it on rent to people to use. or at least with the 4 times insulin you adjust. Miscarriage due to GDM first pregnancy, HbA1c maintained below 5.4, became pregnant. How early you have to say? As early as possible. So as I said, already there's a history of miscarriage and all that. Why are you waiting? As soon as booking comes, as soon as you confirm, you do the test immediately and see whether they are having GDM or not. Role of GLP contraindicated. No GLP, no semaglutide, no tersepatide, no SGLT2, all contraindicated during pregnancy except metformin. No other oral drug is allowed during pregnancy. Completely contraindicated. If they're planning pregnancy, they better stop it 1 or 2 months before they conceive because they've not been tested during pregnancy. Okay, I think we are exhausted all the questions. We've had a lot of questions. So over to you, Dr. Bal.
Thank you so much, sir. We would like to collaborate with you. I will get in touch after this meeting, and then we can start
Absolutely.
right from first onwards from
Yeah.
the next.
So from early
Like
pregnancy,
your-
you start screening, maintain records, if possible, have electronic records, start following up your series. And as we start new projects, we have finished TOBOGM and all now. So as we start new projects, we will definitely include you in that list of collaborating institutions. And we will definitely publications, everything we can do together. And if you have the facility to store samples, that will also be good. Otherwise, you can send us some samples for studies. We are trying to compare early GDM with late GDM to see whether the insulin secretion is different, whether genetically they are different. And all we need is one blood sample, that's all. And with that, rest of it, you don't have to pay for anything. We will do everything free of cost for you. You can definitely take part in many collaborative projects. And thank you all for your kind words.
Thank you so much, sir.
Chat box.
Thank you, sir.
Yeah.
Okay.
Thank you, madam. So we will again after a few months, maybe we'll start some collaborative projects, and maybe after some time we can plan to have one more topic on any other topic of interest, even management of type 1 or management of type 2 during pregnancy and other aspects we can talk about.
Sure.
Thank you.
Thank you.
Thank you so much. Bye.